we've covered a lot of the key studies. There are a lot of unanswered questions, of course, and we covered whether or not PD-L1 negative or low expressors, where they fall in this, and we are waiting for more data. Another issue is the duration of therapy and how long, to go with that. And, we talked early on, you had a patient who is now in year 8. I don't know, presumably not on maintenance therapy at this point.
No, he was on the initial phase 1, and all those trials stopped therapy at 2 years.
Yeah.
Yep.
And so we all have that experience. So what do you think are the guidelines, and are there data that we can use to inform us at this point? Naiyer.
Yeah, so I think we don't know the duration of therapy. I think that there was some data from ESMO 2017, a trial called Checkmate 153, looking at, in the pretreated patient population, looking at nivolumab for 1 year versus nivolumab given on an indefinite basis. And there's certainly, I was actually surprised to see the progression-free survival was considerably better with the indefinite versus the 1 year. Keep in mind that this trial, was not statistically powered to answer that question. It was really more of a safety trial. There wasn't an OS difference, but I think that, nevertheless, I think it was really, validating that that to at least, be continuing these therapies beyond just, 3 or 4 doses, right? So my general practice is that, for those infrequent patients that have a complete response, I'll often continue them for 6 months beyond complete response and stop at that point. There's good data from the melanoma literature with pembrolizumab that if you do that, the durability is nearly 100%. Otherwise, I tend to treat patients for 2 years and stop at that point. For patients that have, moderately severe toxicity or cumulative toxicity and they've had a good response, I'll stop it earlier. I don't think that for the patients that are, having significant side effects that you need to keep going, and I think that it's probably okay to stop.
I think there will be a lot of very interesting discussions around this as we go, and we'll talk about this a little bit later, into adjuvant therapies, how long they should continue, or another item might be the relevance of this information for induction chemotherapy, where we usually give a very short segment of trial drug, and maybe that's not enough, right, and we would have to continue later. So talking a little bit more about this combination, Ram, of chemotherapy and pembrolizumab, the toxicity between those two, you would, in theory at least, be worried that there would be an interaction. What was the clinical experience?
So the good news is the combination of chemo and checkpoint inhibition seems to be well tolerated. When you look at the toxicity differences in detail, fatigue comes up as being slightly more common with the immune checkpoint chemo combination. You also then see some immune-related adverse events. Most of them tend to be grade 1 or 2 that you can manage through or proactively recognize and make sure that that's mitigated with whatever we do next to these patients. So from my perspective, the combination has been overall well tolerated and seemed to be a safe approach for patients. When the phase 3 trials read out, we'll have even stronger information on that topic.
But at this point, we see the single component toxicities, but nothing that's somehow synergistically
That's correct.
Adding more. Have you actually treated patients with this combination?
I have, because now that it's on label, when we discuss treatment options with patients, we're talking to them about this as being a potential treatment option, and the patients that I've talked to have all wanted to go for that approach. So in the past few weeks, I've treated 3 or 4 patients now with the combination, and I've been pleased with at least the safety so far. It's a little too soon to know anything about the effectiveness in those patients.
Yeah. Fred, have you treated patients with the combination?
No, I have not.
And you're waiting.
Yeah.
And Naiyer?
Yeah, I think for the cases where where there's patients are very symptomatic, have a fair amount of disease, you need a more rapid response. I've used it a few times, but I think not consistently. I tend to prioritize some of the immunotherapy combinations that would be trial options for the patients if they progress on chemotherapy, and so I think that that's been my bias.